My name is Professor San Miguel. I'm Senior Consultant of the Cancer Center of the Clinical Universidad de Navarra, and I have been working in multiple myeloma since 1980, when I presented my PhD thesis on immunoglobulin subclasses of multiple myeloma. And since then, I have devoted most part of my life to myeloma patients. Probably it's good just to remember that the first myeloma patient was diagnosed in 1844, and it was not until 1 century later, 1958, that the first effective drug for myeloma was discovered. This was melphalan. And again, since 1960 until year 2000, another 40 years, no real advances, because the only advance was autologous transplant, but was based also on melphalan. Therefore, until that time, melphalan and corticosteroid were the main standard for myeloma treatment. In year 1999, for the first time, a new drug was into the possibilities of myeloma treatment. This was thalidomide. Then it was the proteasome inhibitor Velcade, and this emerged with the IMiDs and proteasome inhibitors, a new two class of drugs for myeloma patients. The third new advance was the monoclonal antibody against CD38. And in 2020, we have, for the first time, the CAR-Ts, the bispecific, and the antibody drug conjugated. Another message that I think is important is that we have moved from triplets, including a proteasome inhibitor, IMiD, and corticosteroid, to quadruplets by adding CD38 antibodies. Therefore, my message, my most important message, is that in the last 2 decades, 19 drugs or drug combinations have been approved for myeloma patients. This means new opportunities for these patients, but at the same time, a challenging situation for physicians. What is the right choice for my patient? And for this purpose, I think we need a compass. In the north, we have patient-specific data, and these include the biological age, the fitness of the patients, the frailty, the comorbidities, the expectation of the patient and the family. We have also disease-specific factors. What are the genetics of the patients? What is the clinical stage? What is the type of relapse? Is biochemical relapse? Is an aggressive relapse? What's the duration of the prior therapy? And what is the bone marrow reserve? The third, we have the north, the south, the east, that is the cardinal point. Also the treatment specificities. What was the efficacy of the prior therapies? What were the side effects? And what is the logistic for the administration? And the last cardinal point is to know the country availabilities for this patient. I think I need to also emphasize that we are facing a high attrition rate in the myeloma treatment at the time of relapse. Both in UK and in Australia, we have data that only 30%, over 30%, 30, 40% of the patients will receive more than 3 lines of therapy. Therefore, the best treatment should be offered upfront or at first relapse. And in the relapse setting, until now, we were facing 2 situations. The first one was the length refractory patients. For this patient, we have opportunities such as to use anti-CD38, daratumumab or isatuximab, plus carfilzomib, that is more effective than bortezomib and dexamethasone. But what happens if you are double refractory to lenalidomide and refractory to daratumumab? In that situation, only a proteasome inhibitor, probably carfilzomib plus pomalidomide and dexamethasone. But these represent really an unmet medical need, and new options are needed to overcome drug resistance. BCMA is a transmembrane glycoprotein coded by the TNF RSF17, and the ligands for BCMA are BAF, and April. It's important to mention that BCMA play a key role in B cell maturation and differentiation. It promotes cell growth and survival, and also chemo-resistance and immunosuppression in the bone marrow microenvironment. In addition, we know that the expression of BCMA is higher in the malignant plasma cell as compared to the normal plasma cell, and the expression of BCMA increase from MGUS to active myeloma. The good news is that now we have drugs that are targeting BCMA, such as CAR T cells, bispecific antibodies, and ADC antibodies. Regarding the CAR T cells, two of them has been approved. One is ide-cel that was approved in 2021 and has approved for patients relapsing after 2 or more lines of therapy, and showed progressive disease to the last line of therapy. The other CAR T is cilta-cel that was approved in 2022 and now is approved in patients that has relapsed after more than 1 prior line of therapy and are len refractory and progress in the last line of therapy. Regarding bispecific antibodies, we have 3 approved. One is teclistamab, 2022, second elranatamab, 2023, and last but not least, linvoseltamab, approved this year, 2025. All of them has been approved for patients after 3 or more prior lines of therapy, including proteasome inhibitors, IMiD, and anti-CD38 antibody, and patients should have progressive disease in the last line of therapy. The third class of drug that we have against BCMA are the antibody-drug conjugated, belantamab, that was initially approved for as monotherapy, but it was withdrawn in 2023 because the results were not the best ones. However, and this is the very good news, now when belantamab has been combined with either bortezomib and dexamethasone or pomalidomide and dexamethasone, and we will see, has shown very good results, and it has been approved recently by the EMA and also is approved in Japan and UK in patients after 1 prior line of therapy. Regarding CAR T cells, we have now the evidence that ide-cel in the randomized 3 trial, KarMMa-3 trial, it has been compared with the best standard of care in patients relapsing after 2 to 4 lines of therapy. And the median PFS in these patients was 13.8 months for the CAR T versus 4.4 months in the best standard of care. Regarding cilta-cel, in the CARTITUDE-4 trial, another randomized trial, a very important trial as well, that has compared cilta-cel versus the best standard of care in a total of 400 patients. These patients had relapsed after 1 or more prior lines of therapy and should be len refractory. The median PFS has not been reached. At 30 months, 60% of the patients are progression-free versus 11.8 months in the standard of care arm. This treatment with CAR T-cell is associated with some toxicities that we should be aware, particularly CRS, also infections, and also neurological toxicity can emerge in this patient. Regarding bispecific antibodies, I already mentioned that we have 3 approved, teclistamab, elranatamab, and linvoseltamab. All of them showed an efficacy between around 60 to 70%. And now we have also evidence that the efficacy is sustained. The median PFS ranges between 1 year, 11 months, and 17 months for tecli and elra. In linvoseltamab, the follow-up is still a bit shorter, but we know that at 1 year, 70% of the patients are progression-free. What is the toxicity in these patients? In the toxicity is CRS, but it's very mild CRS. Infections is the major issue, the major problem in these patients. Regarding ADC, I already mentioned that we have belantamab in 2 very important randomized studies. One is the combination of Bela-VD compared with Dara-VD in almost 500 patients. And the second is Bela-PD, Bela-pomalidomide dexamethasone, as compared to pomalidomide bortezomib dexamethasone. Both studies have shown a highly significant benefit for the Bela arm, 36 months versus 13 months in the Bela-VD versus Dara-VD, and in the Bela-PD versus the PVD, recent data indicate that the median PFS is 32 months versus 12 months in both of them, very high hazard ratio of around 0.4, 0.5. And what is about the toxicity with this ADC belantamab antibody? The major concern is ocular toxicity, but we have learned a lot about how to manage, and it's also going to be discussed. Regarding emergency directions, I think if we focus on CAR T cells, we have one CAR T that is anito-cel that has shown high efficacy and very good safety profile in late lines of therapy. And now we have in earlier lines of therapy, a randomized phase 3 study comparing with a standard of care. In addition, for CAR Ts, we have also clinical trials with dual targeting against BCMA and GPRC5D, as well allogeneic CAR Ts, and last but not least, we have the possibility of in vivo CAR Ts that for me are very attractive. Regarding bispecific antibodies, we have probably will be approved some etentamig that is intravenous every 3 weeks. But what is the most attractive idea of biospecific is the possibility of combining them with anti-CD38 antibodies or with IMiDs, and to move them into early lines of therapy, including the front lines of therapy. But in this area of the biospecific, the most appealing data come from the tri-specific antibodies that are targeting 3 different molecules, BCMA, GPRC5D, and CD3, or BCMA, CD38, and CD3. And regarding ADC, on top of belantamab, we have HDP that is in phase 1/2 trial that is in synthetic amantine payload, and the efficacy is promising. Then overall, for me, what is a lot of new windows are being opened for our patients, and this will contribute to prolong the survival and probably to achieve the dream of curing myeloma in a substantial proportion of patients. Thank you very much.
Hello, my name is Pieter Sonneveld. I'm a hematologist at the Erasmus Medical Center in Rotterdam, the Netherlands. And my field of expertise is in multiple myeloma. I'm also the president of the European Myeloma Network, which conducts large clinical trials for multiple myeloma, both in the frontline and relapse setting. And more recently, we have conducted a number of trials with BCMA targeting agents. So for today, I would like to discuss with you some strategies, how to apply BCMA targeted treatment, how to sequence the treatments, and what are the specific factors that may affect toxicity and efficacy in patients with multiple myeloma. These days, many new agents have become available to treat multiple myeloma. And among those, anti-BCMA targeting treatments are the most promising probably at this stage for treating patients that have first or later relapse of multiple myeloma. So BCMA is a target on the myeloma cell that can be targeted by both using CAR T cells, so modified T cells, or by specific antibodies. And those agents can be really effective if applied in the right way. Sequencing is important because the efficacy of the T cells may depend on the right sequence. And against this background, it's important to know if the T cells of the patient are still active. And exhausted T cells are one of the main factors for a reduced effect of the anti-BCMA treatment. And second, during treatment, especially with anti-BCMA agents, BCMA may be downregulated or even no longer detectable on the myeloma cells. So in order to select the right choice for treating patients with a BCMA targeting agent, we have to know about the mechanism of potential resistance that may be present in the patient. And roughly, these include 3 different main factors, which is the T cell dysfunction. We need active T cells for both CAR T cell therapy and for bispecifics. And if there is a lack of these cells, the T cell effector cells, we might expect less efficacy. Then the tumor intrinsic factors like the general mechanisms of resistance, acquired genetic lesions, but also downregulation of BCMA play a role. And finally, the tumor microenvironment, where there are circulating ligands and molecules that may affect the tumor cell proliferation and lead to a less effective treatment also with the BCMA agents. So we have to know which level of BCMA is still present in the myeloma cells. So when we look to CAR T cells and bispecific antibodies, we now know that especially for CAR T cells, the patients with still a naive or stem cell memory phenotype, so active T cells, they have the best response and the longer persisting response following CAR T cell therapy. So CAR T cells preferably should be applied early on. Then bispecific antibodies can be applied more easily because there are several of them and they are more widely available. But again, they require a setting where the T cells are not yet exhausted. So active T cells mean that the expected response may be longer in these patients. Also, one mechanism of resistance may be that there are high levels of soluble BCMA circulating in plasma, and this affects, of course, the bispecific antibody efficacy. This can be partly overcome by higher dosing of the bispecifics. So overall, the treatment sequencing decision is not an easy one, but there are some data that can provide us with some guidance how to do that. And in more general respect, the CAR T cell treatment should be the earlier one, and the bispecific agents the later one. So we need to consider, of course, several factors. Patient-related factors are well known, not only for this type of therapy, but in general for treating a patient. So you have to be aware of prior treatments, the effect and the toxicity of those treatments. But also disease and therapy considerations are important. So the relevance of the attrition rate, for example, is very important, especially with older patients that can have 1, 2, or 3 treatments, but in general, no more. So the treatment that we select should be effective. And we have to take into consideration factors like refractoriness and the duration of prior response. So in this context, you can go for each of the factors that are important, patient-specific, disease-specific, and treatment-specific factors. But ultimately, the treatment decisions mainly depend, of course, on availability, tolerability, reimbursement, and so on of each of these treatments. And when looking at this, we might have to choose different options in different countries, depending on approval, reimbursement, and other factors that are not directly disease related. So there are several questions relating to the sequence of administering these anti-BCMA agents. It's very clear now that in first or later relapse, a anti-BCMA targeting therapy should be considered because of its great efficacy, high response rate, and duration of the response. The question is between CAR T-cell or anti-BCMA bispecific antibodies. And there are some data, but in general, only from smaller populations of patients and very few from prospective clinical trials. But in general, if we consider the different options, we can state that the first treatment with anti-BCMA is the most effective. A second treatment later on in the disease may still be effective with an overall response rate of approximately 60% maybe, but with a shorter duration. And if the first and the second treatment with anti-BCMA are close together, let's say less than 9 months or less than a year, the efficacy of the second treatment is also reduced, maybe because of loss of expression of the BCMA target or because of T-cell exhaustion or other factors. So in general, if all drugs are available, we would prefer to give CAR T-cell treatment at first relapse. For example, cilta-cel has been approved for that situation. And to save anti-BCMA specific antibodies, bispecific antibodies, or an ADC like belantamab for a later situation, a later progression or relapse. However, in many countries, cilta-cel is not yet available or not approved. And for older patients, it may not be the optimal treatment. Patients of older age might prefer a treatment that is relatively mild, does not have a lot of side effects, and which does not require them to come to the hospital very often. And such a treatment might be belantamab that has been approved for this situation based on the DREAM7 and DREAM8 studies. So this should be seriously considered. And another option is after the initial treatment with anti-BCMA, for example, with cilta-cel, you may bridge with another treatment, which could be chemotherapy, but it could also be another monoclonal or bispecific antibody like anti-GPRC5D, which is a new target discovered for multiple myeloma, and treatment with a bispecific antibody against this target is very effective. It is relatively less toxic, and it does not affect a next treatment with anti-BCMA. So there are several options to consider, and this should of course be discussed with a center hospital that has experience with all these options before making the final choice for your patient. So here you can see some information based on different population studies or clinical studies, usually for the most part in smaller numbers of patients, that shows you the efficacy of different sequences. Sequencing is feasible, however, to make the right choice is not easy. And an informed choice based on, for example, T-cell condition, T-cell exhaustion, target presence on the myeloma cells, etc., done by flow cytometry is very informative, and I would really recommend to do that before making such a choice. So in the future, I think we need a number of prospective clinical trials to really investigate which sequence of treatments is the most effective and the less toxic. How can we prevent infections, for example, with IVIG, intravenous immunoglobulins? Or how can we reduce the eye problems associated with belantamab by rescheduling or changing the dose? Those are options that we need to prospectively investigate before making a guideline. And I could refer you to a guideline that has just been submitted by the European Myeloma Network to discuss all these options and the literature available, hopefully making the clinical practice for patients and helping them to make the right choices. Yeah, so to summarize the data in a very concise way, I would like to mention the following points. So patient screening is very important, and it should be done prior to any bispecific or CAR T-cell therapy, including the, of course, organ functions, but also neurocognitive function because of the side effects associated with, for example, CAR T-cells, infections, and so on. Also, we should consider the treatment-free intervals, and this is very important because T-cell fatigue is one of the main reasons why this anti-BCMA treatment may fail. CAR T-cell therapy, bridging therapy, is important in order to for the T-cells to regain their viability and to avoid T-cell exhaustion. And such bridging therapy may consist of a number of chemotherapy courses like carfilzomib-based treatment or other treatments in bispecific like GPRC5D or talquetamab treatment. And before harvesting cells for CAR T-cell preparation, there should be a washout period. Again, this is all to avoid T-cell exhaustion or diminished T-cell function. And these are main strategies to overcome T-cell fatigue. And it is worth really to invest in preparing for this because T-cell exhaustion is the main failure for CAR T-cell treatment, anti-BCMA, but also for the bispecifics. And I think right now we have indications that with CAR T-cell in first-line treatment, the progression-free survival may be very long. So this is also true for the first relapse. So investing in the right preparation before your patient will be treated with CAR T-cells or with bispecifics is really important, and it will help to make the treatment successful and to reduce unnecessary toxicity.
Good morning, my name is Francesca and I'm Associate Professor in the Division of Hematology in the University of Torino, Italy, and my main field of interest is multiple myeloma. As you know, we have three classes of anti-BCMA agents. These include CAR T cells, bispecific antibodies, and antibody-drug conjugates. CAR T cells and bispecific antibodies have similar side effects, in particular the risk of cytokine release syndrome and ICANS, plus the risk of infections and cytopenias. ADC agents, particularly belamaf, directed against BCMA, is characterized by a different toxicity profile with an ocular toxicity, corneal adverse reaction, plus hematologic toxicities, mainly thrombocytopenia. Infusion-related reactions are very rare. If we consider the two agents, CAR T cells and bispecific antibodies, that have similar toxicity profile, there are anyway differences that are related for CRS for the timing of onset and the risk of grade 3 CRS, which is higher for CAR T cells. The risk of ICANS, again, a bit higher with CAR T cells. Regarding infections, these are more frequent, particularly with the bispecifics, and this is probably related to the continuous treatment use. Hematologic toxicity are also more often common with CAR T cells, particularly neutropenia, and can be a late event. For ADC, as I mentioned, the new toxicity related to this agent is the corneal toxicity, particularly the keratopathy. We can have some hematologic toxicity, but in this case, mainly thrombocytopenia, and then we may have as well infections, which, however, are not so common. So risk factors for CRS and ICANS are similar. One of the a risk factor that is similar both for bispecifics and for CAR T cells is the high tumor burden, the high tumor bone marrow plasma cells infiltration. There are factors that are related to the aggressiveness of the disease. So, for instance, the high-risk disease like the patients with high revised ISS stage. And then there are other factors related to the patients, for instance, like an ECOG performance status of 2 or more. ICANS is more common in patients that have a severe CRS as well. So what can we do for CRS and for ICANS prevention and treatment? For CRS, particularly with the use of bispecific, we may use the step-up doses, so the progressive increase of the dose in different infusion to reduce the risk of CRS, and we can use pre-medication. Something that we can do both for patients receiving CAR T cells and bispecific is if they have a high tumor burden, try to act with treatment anti-tumor, so chemo or anti-myeloma treatment to reduce the tumor burden before the bispecific or with bridging therapy before the CAR T cell infusion. If we consider then the management of CRS, there are specific guidelines. You can use simply antipyretic drugs if the patient has only fever, or you may have to use more aggressive agents like tocilizumab or like dexamethasone, and in specific case, if it's very severe, also anakinra. Regarding ICANS, we can mitigate the risk with an effective management of CRS. We always have to keep in mind that a specific risk factor for ICANS could be also the presence of pre-existing neurologic conditions. Well, cytopenia is more common with CAR T cells than with bispecifics. Could be neutropenia more frequently than thrombocytopenia, and with CAR T cells could be a late toxicity. This may be extremely difficult to manage. We can use GCSF, and we need, of course, to understand specifically what is the cause of the cytopenia, if this is the disease, if this is related to infection, or if this is the inflammation. Regarding the infections, these are instead more common with bispecifics, and probably this is related also to the continuous treatment use and to the very low levels of immunoglobulins that the patients show with continuous and prolonged treatment with bispecifics against BCMA. So we have to use the treatment, the prophylactic treatment, antiviral and antibacterial. Acyclovir is recommended. Cotrimoxazole is also recommended. If there is neutropenia and the patient is a high risk of infection, we can use also other types of antibiotic prophylaxis. But one of the main factors that demonstrated to be able to reduce the risk of infections is the periodical infusion of immunoglobulins in those patients with IgG levels below 400 milligrams per deciliter. Ocular toxicity are new for hematologists treating myeloma patients, and basically we have learned a lot in recent years with the use of the anti-BCMA ADC belamaf. So there are 11 clinical recommendations that are across 4 key themes. First one is related to the screening, identifying and monitoring of the ocular diseases, also at baseline, to evaluate if patients have prior ocular disease that is not a contraindication per se to treatment. Then it's important the monitoring of the patient during treatment with an interaction with the management of the patient. And in case of toxicities, the use of the dose adjustment. What we commonly see is that when we dose adjust with temporary interrupt, we reduce the dose, the ocular symptoms, the impairment in the visual acuity may improve. And almost all the time it improves. It's important for the good management of the patient to have a multidisciplinary team with the possibility to refer to the ophthalmologist. It is recommended at baseline and during the first cycles of treatment, then it would be based on the symptoms. And of course, it's important that there is a patient-centric approach in managing the ocular events, communicate the benefit and the risk of the treatment, talk to the patient to highlight what could be the potential adverse events, and so that the patient can refer them and we can promptly act reducing the dose or maybe stopping temporarily the treatment, restarting, increasing the treatment-free interval between different doses, which is what really helps in recovering the toxicity. There is a very nice paper recently published by Evangelos Terpos on the American Journal of Hematology that goes through all these points and provide clinical recommendation from the management for the management of ocular events.